Another minute as people are filing in the room, so to speak, and then I'll introduce our speakers and set up the talk. Craig, on your slides, are you going to have the QR code for the through the credits?
I don't have the QR code unless Bill. Did you have it, Bill? If you want to send it to me, I'll toss it on right now.
We'll send it to you, and then we'll put it up. Maybe when you do at the end of your slides, and then at the end, like when you're transitioning to Mark, and then at the very end. Okay, I'm going to get us started.
I think I was on copy. All right, go ahead.
Great. I'm gonna go ahead and get us started, and so welcome everybody to Grand Rounds. I'm really excited today. We're in for a treat. We have actually, since I've been doing this is I think the first time I've been able to introduce a team for the talk, which is on harm reduction, opportunities for engagement. And before I introduce that, just a reminder for people, we do the presentation until about 1. And then we have 15 minutes for questions and answers. And the ways to let us know if you have questions are several. One is you can use the chat function, which, as it turns out, very few people do, but it is. I'll keep reminding people, it is the swear thought bubble on the top left, which I will monitor. You also email me, and somehow a lot of people know my cell phone. You can text me questions as well, and I'll facilitate the back and forth discussion. So let me go ahead and get to introducing real quickly our speakers again for harm reduction, opportunities for engagement. We've got Mark Jenkins and Dr. Craig Allen, who many of you know. So I'm gonna start with Mark. I'm gonna read from a bio. I just got to meet him. I've heard great, amazing things about him. So Mark Jenkins is a service-connected disabled veteran of the United States Air Force and founder and executive director of the Greater Hartford Harm Reduction Coalition. He's worked in the field of harm reduction and public health for the past 23 years, delivering innovative prevention and interventions to the most vulnerable members of Central Connecticut communities. Mr. Jenkins started in the field as an AIDS risk reduction outreach worker. The abbreviation for that is ARROW, for the perception programs in Willimantic. In his subsequent work with the Community Renewal Team and the Hispanic Health Council, he further cultivated progressive strategies for reaching and delivering services to our most difficult to reach populations. Mr. Jenkins's work in some of the most troubled neighborhoods in the state has given him a unique perspective on the history of drugs and drug trends and the dynamics of associated risks and effective public health responses. Over a decade on the staff at the AIDS Project Hartford as a drug treatment advocate, providing HIV and HCV counseling and testing, syringe exchange, and other harm reduction services. Mr. Jenkins developed a service network of providers that continues to benefit both client and staff of various providers alike. The breadth and depth of his connection with folks on the street and service community has made Mark a well-respected and widely known individual in this field. He has presented nationally and internationally about best practices for working with the drug-using community. We're really, really lucky to have him here. He's in high demand. And we're going to start with Dr. Allen, Craig Allen, and I'll just really I have a very brief, but thank goodness, because this could go on for a while. Many of you know Dr. Allen and all of his work. So for those few of you that don't know Craig, Dr. Allen is the director at Rushford, chief of psychiatry at Mid-State Medical Center, and vice president of addiction services for the Behavioral Health Network here at Hartford Healthcare. He co-chairs the treatment subcommittee for the state of Connecticut's Alcohol and Drug Policy Council, is on the advisory board for the Department of Mental Health and Addiction Services here in Connecticut, as well as the Addiction Medicine Committee and Opioid Task Force for the State Medical Society. Dr. Allen lectures and advocates locally and nationally for prevention, screening, early intervention, and treatment access for substance use and other psychiatric disorders throughout the lifespan. And he is board certified child, adolescent, and adult psychiatry, as well as addiction medicine. I just very quickly, on a personal note, would say that, I mean, you know, he's in a realm now of achievement in a career. I expect Mark is as well, where the world is different because of what they've been doing, and it's better because of what they've been doing, and they have obviously a lot more still yet to do, but that's a particular kind of achievement. So with no further ado, I'm going to turn it first over to Craig. We'll go for about until 1 o'clock, and then we'll have Q&A. So, Dr. Allen?
Thank you very much. Please remain seated while I put my slides up here. Mark and I are used to that kind of applause. So let's see how we do this. All right, we're going to share. And let's see where we're at. Someone give me a sign that I've made it to the screen.
I see it. I see you, and I see the slides. We're good.
Excellent. Okay, harm reduction.
And I can hear the laugh track. And I can hear the laugh track.
Excellent. So I like to start off my presentations with this slide because I want to, particularly when I'm talking to a behavioral health audience, I want to remind people of the fact that substance use disorders co-occur with psychiatric disorders at a very high rate, and vice versa. And in the United States, although we spend the most per capita on healthcare, we rank in the world 27th in life expectancy. And the reason for that is increased mortality secondary to substance use, misuse, substance use disorders, the physical problems associated with that, and mental health problems, suicides, and overdoses. So to sum this up, Vivek Murthy, who was the former Surgeon General, said the treatment gap is a direct result of the lack of access to affordable care, shame, discrimination, and the absence of screening for substance misuse and substance use disorders. And those are things that all of us can actively do something about. So I also like to include, always have to include a slide on COVID-19 ever since March. But prior to that, planned prior to that and occurring on March 2nd was a visit that Hartford Healthcare had from the gentleman seated in the picture there. That's Jerome Adams, the current Surgeon General. And the Surgeon General was coming to Hartford Healthcare, did come to Hartford Healthcare in March to find out what we were doing as a healthcare system about the opioid overdose crisis. So the epidemic of opioid overdoses was raging before the pandemic was raging. And now it is this epidemic within a pandemic. Now I was very excited about the Surgeon General coming and very focused on delivering a clear and concise message of all of the different things we have been doing and trying to do and we've been building towards addressing this problem. My boss, both of my bosses are seated next to me there on the panel. Their bosses and their bosses' bosses are in the audience, as well as some politicians. And so I wanted to make this happen. And I knew the work that the Surgeon General had done in the past around opioids, and I wanted to make us I wanted to give an accurate picture of what we were doing. I was not paying attention to anything else going on in the world, and I didn't notice when our Chief Medical Officer, Ajay Kumar, was elbow bumping and others were elbow bumping. So when we finished on stage, I went to get my selfies, and I wanted to shake the Surgeon General's hand. I stuck my hand out. He grasped my hand because he is a gentleman, and at that point, I became the last person in the United States of America to shake the hands of the Surgeon General. So that's my claim there. COVID has engulfed us since that time, and I don't have to tell any of you about the impact on our lives with the disrupted routines and all of the added stressors. But the impact has been disproportionately large on our patients, and people with substance use disorders and psychiatric disorders have had a particularly difficult go of things. There's been an increase in depression, anxiety, and substance use and opioid use disorders. At the beginning of this pandemic, a report came out which suggested there would be 75,000 additional deaths of despair. So deaths of despair are overdose deaths and suicide deaths. And that number was jacked up to 150,000 in July. We are seeing this happening. The state of Connecticut last year in 2019 had the highest number of opioid overdose deaths ever in this state, and we have one of the highest rates in the country. And in 2020, we are on track, unfortunately, to beat those numbers by more than 20%. So we need enhanced strategies and tools to connect and engage with people who are at high risk. And this talk today will address some of those opportunities. So here are the objectives for this talk today. Want people to be able to describe the role of harm reduction strategies, decreasing opioid overdose deaths and infection rates related to injection drug use, be able to educate patients on strategies to reduce risk while building relationships that can facilitate entry into treatment at some point when people are ready, and be able to integrate harm reduction strategies into your daily work. There's a picture here of Connecticut medicine. This special edition came out with COVID. It seems like maybe 5 years ago. It was, the date's down there, May of 2019. In this edition, Mark Jenkins and Robin Deutsch wrote an article entitled Optimizing the Health and Safety of People Who Inject Drugs, Harm Reduction and Healthcare Providers. I'd encourage you to take a look at that. If you have any trouble finding a copy of this journal, which I was a co-editor for, you can contact my mother. She has the 1,400 remaining copies available for you. So some of you might be familiar. Today with all that's going on politically, I wanted to stay away from politics. So that's what I will be doing and share with you a journal article. This is from the New England Journal of Medicine, 2016. Some of you may be familiar with this. I know Mark is intimately familiar with this. This has to do with a Midwestern state, Indiana. Indiana, over the course of 5 years, had 5 HIV infections. And then suddenly, over the course of 5 months, they had 18 or 20 of these infections. Now, the state of Indiana and their Republican governor had pretty strong and clear feelings about harm reduction programs and syringe exchange programs. They were illegal in the state of Indiana. And the newly appointed director of the Department of Public Health, been there for 4 months, was brought this information about this uptick in HIV infections and was tasked with convincing the Republican governor of the need for this type of programming, syringe exchange and harm reduction. And to his credit, he was able to convince Mike Pence to give a 30-day moratorium and allow for the setup of a sterile syringe exchange program. And then after that, got that extended. And now there are programs, legal programs in the state of Indiana. That was Jerome Adams, who was the director of the Department of Public Health and our current Surgeon General. And you see from the slide here the number of HIV infections after putting in place harm reduction programs. They dwindled down to nothing and very low rates. So the epidemiology of HIV infection in people who inject drugs, sharing needles, syringes, and other injection equipment are high risk for hepatitis B, C, and HIV, as well as a number of other infections, and endocarditis, infection of the heart valves. Substance use increases risky sexual behaviors. I try to stay away from these sexual topics. It make me so uncomfortable, but I'm sure Mark, I know Mark is not uncomfortable talking about them. But those increased sexual transmitted disease also increases, of course, the risk of HIV infection. Substance use is associated with lower rates of people taking their medications for HIV, so the antiretroviral therapy, and other medications like PrEP, which is the pre-exposure prophylaxis medication. Social and economic factors limit access to HIV prevention, treatment, and services, and stigma, discrimination, and mistrust of the healthcare system prevent people from seeking testing, care, and treatment. There's also a lack of access to substance use disorder treatment, including medication-assisted treatments. So principles of harm reduction, a set of practical strategies and ideas aimed at reducing negative consequences associated with substance use. Also, a movement for social justice built on a belief in and a respect for the rights of people who use substances. Interventions are guided by risk-benefit analysis. Abstinence is not a prerequisite to care, and the idea is to meet people where they are at. Every interaction allows for building trust and a therapeutic relationship. And when people are ready for treatment, they know where to go, or when they're ready to address substance use issues, then they can engage. Some and another way of talking about harm reduction programs, some people say risk mitigation programs. These are examples of risk mitigation programs that are well researched and evidence-based. One is a naloxone overdose education and naloxone distribution. And I've listed some information there. It's usually I have a big slide with all of this showing the efficacy in decreasing overdose deaths. Opioid overdose education naloxone programs do not increase use. They decrease overdose deaths and increase the number of people actually getting into programs. Medication-assisted treatment, buprenorphine and methadone, also well researched, and we know about their efficacy in decreasing opioid overdose deaths by over 50%, but also they're quite efficacious in decreasing HIV transmission and transmission of other bloodborne illnesses. And then syringe access programs, a number of studies, many studies show how effective these programs can be in reducing the spread of infectious disease, as well as engaging people in treatment for infectious disease, mental health issues, and substance use issues. So treatment outcomes when medication-assisted treatment can be paired with HIV information and HIV treatment have been very positive. Reduce community viral load, reduce risk of transmission, lower risk by reducing the use of syringes. Being engaged in MAT programs that also provide infectious disease treatment can increase adherence to antiretroviral drug therapies and decrease morbidity and mortality from those infectious diseases. The Brownstone for Hartford Healthcare with Robin Deutsch, that's one of the strategies that they use over there. She's an infectious disease doctor. Many of you may know her, and an addiction medicine doctor. And she does a lot of work with Mark as well. So harm reduction services can include all of these. Free sterile needles and syringes, safe disposal, referral to mental health services and substance abuse treatment services, HIV and hepatitis testing, hepatitis A and B vaccination, overdose education, access to naloxone, and these syringe service programs do not increase illegal drug use. They do not increase crime in the neighborhoods they're located in, but they do reduce HIV transmission. Integrating HIV with harm reduction services has been shown to be quite effective in reducing HIV mortality. These are the things that you as a provider should be thinking about when you're seeing your patients. Screening for substance use disorders and misuse of substances, including prescription opioids, and then being able to provide a link or actually provide the medication-assisted treatment. If someone does have an opioid use disorder, you should be able to refer people or order testing for HIV and hepatitis, and then encourage treatment and support treatment, encourage vaccinations when they're appropriate for A and B, and testing for sexually transmitted disease, and then education around for someone who is actively using. And this, for some people, this is a novel idea. If someone is actively using drugs and is either not planning on stopping or is, as many of our patients do, struggling, it's important to talk about harm reduction strategies like not sharing needles, educating on washing hands, bacterial infection, and even suggesting other routes of use, providing or referring for HIV risk counseling, and prescriptions or provision of PrEP, and very, very importantly, providing naloxone or referring to a program that can dispense naloxone. And some harm reduction strategies include, and this is something really anybody should be talking to a patient who has an opioid use disorder and has injected, be talking to them about not using, and even if they're not injecting, discourage using alone, educate on overdose risk, particularly when someone's tolerance has gone down, so like after a hospital stay or after incarceration. And encourage as much as possible knowing the source of the drug that you are using with the very, very potent synthetic opioids that are all over the place, fentanyl and fentanyl analogs, very high risk of overdose and death. So some interventions that are taking place, harm reduction, risk mitigation through Hartford Healthcare. I mentioned Dr. Deutsch's work over at the Brownstone. There's the cardiology and cardiothoracic surgery. This is for the endocarditis team. And Monica Kloof is one of the nurse practitioners that leads that team up. And Kathleen Vies is their nurse navigator. They have done really an exceptional job. You guys, some of you I know are familiar with their work. Maybe a lot of you are familiar with their work. They identify patients who are using and offer induction onto medications while they're in the hospital, and then help to transition them to getting treatment in the community when they leave. Naloxone distribution, this has taken place across the system through our behavioral health programs. At Rushford, we educate all of our patients and offer all of our patients prescriptions. If someone were to leave one of our programs prematurely, such as our withdrawal management detox program or residential program, we make every effort to have them leave with a naloxone kit, and all of them get the education. Our emergency departments have been able to give out naloxone, and one of the strategies for the Opioid Stewardship Council here at Hartford Healthcare is to have our acute care programs focused on the need to provide naloxone for patients with diagnosis of opioid use disorder on discharge. Safety kit distribution, this is clean syringes, and Mark Jenkins has worked with us to get safety kits into mid-state medical centers emergency departments, so people who may be come in with an overdose and they're using injection drugs, and they're not ready for treatment when they've lost their needles when the police pick them up or the ambulance came or so forth. They're at high risk of going back to use and high risk of using dirty needles or damaging needles. And so we provide those kits at Mid-State Medical Center ED, and we're making a recommendation from the Opioid Stewardship Council that Hartford Healthcare look at a way of resourcing and funding the ability for us to provide those kits in all of our emergency departments. I want to mention the Explorers Group over at our Community Behavioral Health Center in Merida, and this is a program for people who are continuing to use, but they are engaged in treatment. And the goal is to be there and ready for them when they want to try to get into recovery. But in the meantime, there's many benefits we can provide by supporting them and providing other services that they're that they're engaged in other psychiatric services or risk reduction services. And finally, the MORE program, which is Meriden Opioid Recovery Response. This is a grant-funded program with the Department of Public Health in Meriden. It's an outreach program, first responders who have revived someone with naloxone. Naloxone, the opioid overdose reversal medication. They've overdosed. They have an opioid use disorder. A team led by John Potter will go out into the community, recovery support specialist. John Potter is a clinician. In case there's a case manager, and they will try to engage this person. Oftentimes, those people do not want to come into treatment at first, but there's other needs that they may have, and we try to establish a relationship. Many of those patients have transitioned into treatment. And I just want to show you 2 quick slides, and then we'll move on to Mark's work. This is an engagement slide. We have new data coming out, but this is after the first year. And it shows the blue is engaged in Rushford services. The turquoise is community-based services. These are people that our MORE team remains connected to. And as people finish at Rushford, they may transition to community-based programs. This next slide is actually pretty startling to me, and we'll see what it looks like for 2020. But this looks at opioid overdose deaths in the city of Meriden versus a like city in East Hartford. 2017 is prior to this program. 2018 is when this program started. And the opioid overdose deaths have gone down, while in a like city, East Hartford is the one that's being used for comparison. The rates have not significantly gone down. And across the state of Connecticut, as I mentioned, both the rates and the total number of people dying has increased. This is just a list of different types of interventions. What I want to do is transition to Mark Jenkins. And so you can bear with me while I use my high-level skills to pull up Mark's presentation. I'll put this one away. And do you guys see the drop, GHHRC?
I see the slideshow. And Mark, you want to turn on your camera, then we'll be able to see you. And Craig, you're going to advance the slides.
I will advance the slides. Mark will tell me. I just want to let people know that Mark, you've heard of physical actors or physical comedians. That's how I've thought about Mark. I've seen him present live almost exclusively. I don't know how often. I've seen him on Zoom a lot, but I don't know if I've seen him present. I don't think I have. In person, he is memorable. At some point, maybe you'll be able to see him do this in person. We'll see how, I guess we'll all find out what it's like to hear him talking to us on this on the screen. So Mark, you tell me when you want me to advance the slides, and remember there's like a 3 or 4 second delay.
Can you see me?
Not yet. I can.
Can you? On.
Ladies and gentlemen, Mark Jenkins.
Hey.
If you can't, it may be Mark, that because this the screen is being shared by Craig, that his video that just might be the way it is. But let's see how it turns out. If your video is on, maybe you'll come up in the record. I'm not sure.
You guys can't. Can you guys see me in there? Am I on there?
I can see you, Craig. Yeah.
So if I had a picture of Mark, I could pull it up.
Yes.
I'll try to find a picture.
So Craig, you might be able to get your camera. And it might leave you.
What, Bill?
I asked him to mute his camera. That may remove him from.
Oh, if Craig, if you turn off your camera.
You guys are daring.
Let's see if that works. See if that brings up Mark.
Yeah, maybe that'll bring him up.
Well, we'll see. It popped. Okay, there it is. Yep. All right, Mark, I would just go ahead.
I can describe Mark for all of you guys.
Yeah, I bet you can.
But I'll refrain.
Okay, so thank you for the introduction and for the information. Yes, he is right. I am a lot more animated in person, so I try and make up for it through Zoom by swearing an awful lot. But no, I will refrain to the best of my ability. Uh, as Dr. Allen mentioned, my name is Mark Jenkins. I'm the founder and executive director of the Greater Hartford Harm Reduction Coalition. I am a harm reductionist by trade, so I'm a different sort of a fellow. It's my job. It's my duty. Some would say if it weren't for my language, my ministry, if you will, to help individuals reduce the amount of harm they cause themselves and their communities as a result of illicit substance use, and to also work with other organizations and entities that work with similar populations. I have at times been called an enabler, and I have a snappy two-word comeback for that, but it doesn't generally stimulate good conversation, after that. So I've had to kind of take a step back and figure out a way to articulate a response when I get that, is because, I am an enabler of sorts. We enable people to stay alive. That's really at the end of it all. It is my job to help people find ways to stay safer. While they engage in various activities that may have negative consequences to their health. So what we're going to be talking about today actually is the DROP, which is our resource center on the north end of Hartford. We have an office also here on the south end on Grand Street, which is a few blocks from where you are at the IOL. But the DROP, and you can move. All right, good. You've already moved forward. Has been in operation since September of 2018. It actually opened, to be honest, the soft opening was on International Overdose Awareness Day, which is August 31st. And it's designed to be a low-threshold drop-in center, allowing us to engage people and provide harm reduction services to at-risk individuals. You can move along. You can move. Hello? Hello? Alrighty. Okay. The impact of that to date, and actually, we didn't realize. We had an idea based on a location that it was going to be in the right area. We just had no idea of the amount and number of people that we would begin to service. And you can move on, Craig. Alrighty. The success of the drop-in center has been, because of, number one, our non-judgmental approach to providing services, grassroots, peer-based engagement, culturally competent programs, and as I said earlier, location. Location. We're actually located across the street from an FQHC, which people said, well, why are you going to open up, across the street from there? People already, grab services and things from across the street. And what a lot of people don't realize is populations we serve don't generally enter or receive treatment and services through front doors. Many of them, don't receive services until there's emergent need. You can move forward. emergent need, and or incarcerated. Move forward. So we're located in or on Albany Avenue in the North End, and an example of our effectiveness happened last year. If you remember, we had an incident of fentanyl-laced crack cocaine in the North End. And initially, it was thought that approximately 8 people or 8 fatalities within a 24-hour period. But because many of these were folk that we worked with and served and have that connection to the community, we were able to actually dispatch people to other folks' homes and locate several more people in their homes who had deceased. Move along, please. Next. So we actually moved in, and you can go on for the next couple slides. These are just pictures of what it was when we came into this space. So it was an old, like, juice shop, not a whole lot of space. I had an idea for what I wanted to do in there, so we had to, kind of map out and use every bit of space that was available. I wanted to put a shower in, but it didn't look like it was going to happen. But we managed to get the work done, get the doors open, keep going. And, I got to tell you, I thought it was one of those things like the Field of Dreams. If you build it, they'll come. So we stocked it, did everything we would normally do on the street, and got the doors open. Now, stop there. Now, what you can't see from the front of them is, stop right there, please, is these two banners. You can go back to the other one because you're seeing the back of them right now. And that's really what people were greeted with when they came. You had the one on the left, which talked about HIV, and the one on the right, which, stated, know what to do when you need to. And that was for naloxone and making sure naloxone, got into the neighborhood. But what we found out was when people came to the door and said, hey, what do you do there? And we mentioned these things, it was like, no, never mind. Never mind. I'm okay. And they keep moving. And keep in mind, this is a very high traffic area. But just the mention of HIV testing out front or naloxone distribution out front, many people backed off. So we had to take a step back and realize just how important language was. You can go to the next slide, please. So, I really wanted the building to look like this out front, but we didn't have the budget. So in the next slide, you'll see what we ended up with. Didn't have all those graphics. And if you know me, you know I'm all about branding. But by the time it was open, all I could use was the first banner that I did like a few years back in 2014 and used some double-sided tape to stick it in the window. But what we did begin to do, and what I've always done, is continue to produce information, printed information. Maybe it's from my old background and, the club days as a DJ and everything. Next photo, please. But what we had to do was let people know that we were different things to different people. So when people came by and say, hey, what is it you doing there? well, what is it you need? How can we help? We're different things to different people. For many of the young population, we did things like keep specialty condoms, like Magnum condoms. If you know, and it doesn't even have to be minority populations. If you've got a 20-something-year-old population, they all want to see that gold wrapper condom. And it's supposed to be, they're supposed to be larger, if you will. And, most of those populations have big egos. So we know they have big egos. They want specialty condoms or even just being able to say they have one. It really doesn't matter to us. But what I started doing also was buying the lifestyle condoms and the gold wrappers because they're a hell of a lot less expensive. And, they use those just as well. But, so in keeping with the basic principles of harm reduction, the center was, designed and dedicated to serving the most vulnerable people in the communities and with the thought of meeting people really where they were at. Next slide, please. So when people would come up and they would say, what is this place? What are you doing here? We begin to understand and really see firsthand that the hierarchy of people who use illicit substances was alive and well. That stigma was alive and well, and poverty-stricken neighborhood, just as it were, across Avon Mountain. And NIMBY existed, right there. So what we realized was we had to be careful not to scare or shame or embarrass anyone looking for services, but more importantly, not to volunteer too much information to people who really didn't need it. So with that in mind, and adding a coffee pot, because a strategically placed coffee pot will do wonders. So we went from no one in the building to, next slide, to the space looking like this, and part of the messaging that we told, people early on is that, we're a safe place. We're a safe space. If you just need somewhere to sit down and come in, out of the elements, come on and do so. We had to understand, and we designed the bathroom and put the bathroom together, understanding that, there are many public consumption spaces, throughout the city of Hartford. McDonald's, Burger King, Dunkin' Donuts, local library, and Hartford City Hall. The basement at City Hall, and this is, known, is a quiet space. It's dark. They can go in there and get high without, any consequence. But unfortunately, those spaces are unsupervised. And as a result, we've seen in the libraries and in all of those spaces, many fatalities or, definitely many overdoses. Next slide. So it was thought early on, people would say, hey, you guys are a SIF. We're not a SIF. SIFs are illegal. SIFs are also, if you don't know what a SIF is a safe injection space or safe injection facility. One of the most popular in North America is a place up in Vancouver, British Columbia called Insight. Insight is a safe injection facility. There are medical staff on board to monitor people. We have a bathroom. We have a bathroom that was designed with the mindset that anyone who uses our bathroom, because we have all of the harm reduction supplies there, syringes, everything that's needed, if people use other bathrooms in the city to get high, we had to really protect ourselves and protect the people that we serve from harm's way. So we knew that everyone who uses our bathroom will have the opportunity to use, so we instituted a 3-minute rule. And when anyone goes into our bathrooms, there is an alarm will go off after 3 minutes, and you'll hear the beep, 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 and you'll hear someone from behind the door go, "I'm okay." And, we'll reset the timer, and, and within a reasonable amount of time, people, can do whatever it is they're doing behind the doors. Now, if someone does not respond, and the staff will always ask if someone's okay. They will never knock on the doors, just in case someone is injecting or has a syringe in their arm. You don't want to startle them and cause injury. If no one responds, the way the door is situated, the door opens outward, not inward. So if someone falls out behind the door, the weight of their body won't be behind the door to block entrance. And the protocol goes into action, and that protocol is standard for any overdose, if you will. That would be to stimulate a response, check to see if they're okay, are they breathing. If they're not breathing, first and foremost, to call 911. If they're not breathing, to do rescue breathing. We don't do CPR. It's just rescue breathing if they aren't breathing, and administer naloxone or Narcan. We always have several different types of formulations on hand, intramuscular, Evzio, or nasal Narcan. So, there's generally something to help someone. Next slide, please. Next slide. I don't know how that got up there twice. All righty. So from day one, and I will say, to date, we have not had any fatalities. We have had people overdose. We've had people walk in and sit down and go into an